Trauma-associated glaucomas is a diverse topic. Trauma by itself can cause an inflammatory reaction in the anterior chamber that can either increase or decrease the intraocular pressure. And there are a number of other processes that can lead to intraocular pressure elevation. Some of these involve lens injury, and these are covered under lens-induced glaucoma lecture, including things like ectopia lentis, lens particle, phacotoxic. What we're going to talk about in this talk are angle recession, hyphema, ghost cell, siderosis, and burns. So angle recession occurs in the setting of blunt trauma, in which the trauma is transmitted into the face of the ciliary body and causes a shearing injury through the ciliary body face. And you can see here that the ciliary body is torn and separated from the wall of the eye. This separation that we see at the asterisk is artifactual. But this part of the ciliary body should be attached here, and you can see that it's just torn into. And it's always striking to me, if you look at these histopathologic images, if one simply photoshops out this little band of tissue here, then it's a cyclodialysis cleft. So very close to a cyclodialysis cleft histopathologically, but not in terms of patient management. Angle recession is simply a sign of severe blunt trauma in the neighborhood of the trabecular meshwork. So the recession itself does not cause damage. It just means that the trabecular meshwork has been in the vicinity of significant trauma. The analogy I use with patients is that if you walk into your living room and the television set isn't working, and you see a hand grenade crater in the floor in front of it, that might be a clue as to why your television set isn't working. There are other signs of blunt trauma that you can see when you do slit lamp exam. One might see sphincter tears or iridodialysis. The case on the far right is a patient with near total traumatic aniridia. Vosius ring we see less often. That's a ring of pigment that is deposited on the anterior capsule of the lens as the iris slaps back and just leaves this little tattoo of pigment on the anterior lens capsule. When we examine an angle that has recession, we see that the ciliary body face is wide. It's usually lighter in color. If you think of it, we've sheared down in the ciliary body face, and now there's very little ciliary body between the examiner and the sclera. For reasons I can't explain, sometimes the ciliary body face is very dark, but typically it's light in color. If there are iris processes, and certainly not all eyes have visible iris processes, then those might be broken, and we'll show an example of that in a minute here. And sometimes the scleral spur will stand out as a very distinct white line, which we don't see in this photograph on this slide. But as we strip away some of the ciliary body tissue, then one can see the scleral spur standing out in bright contrast. In this particular patient, we see these three little dots in the inferior angle, and this is old blood, the remnants of old hyphema. A little bit washed out photograph on the left, but this is a patient with unilateral angle recession, and when we compare the normal eye on the right and the abnormal eye on the left, we can see that the ciliary body face here is much darker than it is over here. There are some iris processes here that are not visible in this eye. The width of the ciliary body face is much wider here. Sometimes, and not often, we can see these tangential tears in the ciliary body face. And again, notice how wide the ciliary body face is. And in this eye, you can see how bright the scleral spur is here as opposed to here even. This whole area, though, is recessed. Just a video of a recessed angle. You can see the scleral spur here, pigmented trabecular meshwork, this very wide ciliary body face. And it's important to compare the two eyes. Some people who are highly myopic will have a very wide ciliary body face anyway. This patient has this tangential tear. I've shown 2 examples of this now, but it's not a very common finding, but it really lets you know that there's been trauma there if you can see the tear right there. My favorite video of angle recession, this is a patient who has tons of iris processes. And so in this area, you can see that there are no visible processes because they've been broken. But now we're picking up iris processes here, but there are none here. And that actually lets us see exactly where the angle recession ends. It goes in this area, but not in the area to our left. Recessed, not recessed here. You can see there's iris processes and then they just start to disappear. Now most eyes don't have iris processes like this, but it really makes for a great example. Angle recession is the differential diagnosis of unilateral glaucoma, particularly in young men. It can develop years later, so if we see somebody with angle recession today, we really need to follow them forever. The risk is not high. It's about 6% of eyes with 180 degrees of angle recession will develop glaucoma over 10 years, so somewhat under 10% at 10 years. But when we think about young individuals who are usually the ones who are getting angle recession, that's a very high rate of developing glaucoma. Because most people don't develop glaucoma, it's been found that there's an increased risk of developing primary open-angle glaucoma in the fellow eye. These may have been eyes that were already predisposed to developing glaucoma. So if we have somebody with angle recession in the right eye, and even if the eye is doing great after surgery, one always needs to follow the fellow eye because it is at some increased risk of developing primary open-angle glaucoma. It's treated like primary open-angle glaucoma. Cholinergic agonists, which we don't use much anymore anyway, like pilocarpine, can sometimes paradoxically elevate the pressure. Trabeculoplasty is less effective than it is in primary open-angle glaucoma. Trabeculectomy can work. I typically don't do iridectomies in most of my trabeculectomies anyway, but if one does a trabeculectomy with an iridectomy, need to be concerned that there might be some loose vitreous broken zonules behind the iris. Hyphema. You see a little tiny hyphema in this picture on the right, bleeding into the anterior chamber. Blood, plasmin, fibrin, and debris can all obstruct the trabecular meshwork and cause the intraocular pressure to elevate. A second mechanism is that in a total hyphema, the blood can mold through the pupil and actually lead to pupillary block. And the risk of developing glaucoma is related to the size of the hyphema. So a very small hyphema with an iridodialysis here on our left and a very large hyphema on our right. And I'm not sure that the numbers are things worth memorizing, but under 50%, the risk is pretty small. Over 50%, it's about a quarter of patients. And then 100%, it's about 50-50. And then an 8-ball hyphema, which is black and basically means that there's no circulation into this hyphema, the risk is 100%. People who have sickle cell disease or sickle cell trait even have a much harder time clearing blood from the anterior chamber because the sickled cells do not deform to go through the trabecular meshwork. they're at a greater risk of pressure rise, and they're also more sensitive. Their nerves are more sensitive to high pressure. So this is a group that needs to be treated very carefully. Long-standing large hyphemas in the face of high pressures can lead to corneal blood staining, as we can see here. Corneal blood staining almost looks like a dislocated lens, but this is in the cornea. There's generally clear zone, and it's almost always perfectly round like this or like this. One doesn't get blood staining with normal pressures usually, and one doesn't get it with the small hyphema. It really takes a very large hyphema and high pressures. The exception would be in children who have relatively permeable corneas, and so they can get corneal blood staining without a markedly elevated pressure. This is just a video of a boy who has blood staining, and this is over 14 months, just to show how long it can take for blood staining to go away. You can see it clears from the periphery in a pretty crisp margin. This is at about a year. And then finally at 14 months, the blood is gone. Not only do children get blood staining more readily, but we also have a concern of them developing amblyopia if they're of the amblyogenic age. Treatment is at controlling the pressure, and critical that we prevent rebleeding. And there's a lot of controversy about rebleeding and how to prevent that. Usually the first 7 days are the most critical time. We avoid blood thinners, so these people should not be put on aspirin or other things that can thin the blood. Usually protect the eye with an eye shield. Elevate the head of the bed so that the blood settles inferiorly, and typically at rest. If it's a responsible adult or a child with responsible parents, they probably don't need to be at strict bed rest. They just need to take it easy for these 7 days. Aminocaproic acid, or Amicar, has been shown to be a benefit in preventing rebleeding. It prevents contraction of the clot, but it has a host of side effects, including nausea and vomiting. And frankly, I've never used Amicar for my patients. There are conflicting reports on the benefits of corticosteroids, conflicting reports on the benefits of atropine and other cycloplegic agents. We treat the pressure with aqueous suppressants and the usual glaucoma drugs. We avoid cholinergic agonists like pilocarpine. Beware of oral carbonic anhydrase inhibitors in patients with sickle cell disease because of the risk of acidosis and perhaps encouraging sickling. And similarly, adrenergic agonists like epinephrine and dapivirine, these are drugs we don't really use anymore, can cause anterior segment vasoconstriction, which can be a problem in patients who have sickle cell disease. But in reality, these are drugs that we don't use. We typically, if we're going to use an adrenergic agonist, we would use brimonidine. Sometimes one needs to wash out the clot, and the ideal time to do this is around day 4 when the clot starts to lyse. For me, I would prefer to do a trabeculectomy if I'm going to take patients to the operating room. I don't use antimetabolates. I do that for 2 reasons. One is that it gives me a much bigger opening to flush the blood and clot out through. And the other is that these patients, as I said earlier, can get almost like a dumbbell-shaped clot that fills the anterior chamber and also occludes the pupil. And so there is an element of pupillary block in some of these patients, and doing an iridectomy can relieve that pupillary block. And when I've done iridectomies in these patients, there's also often a gush of aqueous that comes forward. These patients are at high risk for developing angle recession, but I would not do gonioscopy on them for several weeks until the risk of rebleeding has passed. Ghost cell glaucoma results from a long-standing large vitreous hemorrhage. Emphasis on long-standing. So if a patient has a brand new vitreous hemorrhage, they're not going to get ghost cell glaucoma. These red cells degenerate over 1 to 3 months, and they become ghost cells. They denature and become these ghost cells. Histopathologically, they are round cells like this. If the hyaloid is disrupted, the cells reach the anterior chamber where they can clog the trabecular meshwork. So certainly in a case of trauma, it's not unimaginable that the anterior hyaloid would be disrupted, or if somebody's had a pars plana vitrectomy or any other major surgery. These cells are inflexible, and unlike the normal red blood cells, they cannot deform and pass through the trabecular meshwork into Schlem canal. On exam, we see khaki-colored cells in the anterior chamber, like the picture here. This is a patient with traumatic aniridia. She's recently, post-cataract extraction, fell and pushed her entire iris out through her cataract wound. She has a vitreous full of blood, and as you can see, it has this khaki color, and I show this mostly just to show the color of ghost cell glaucoma. These cells can form a pseudohypopion, so a khaki-colored hypopion. And if there are bands of fresh blood among the khaki-colored cells, then this is called a candy stripe sign. It's treated typically by treating the vitreous hemorrhage by a pars plana vitrectomy. Aqueous suppressants, always the right answer for any kind of secondary glaucoma, and the usual glaucoma drugs. Siderosis is retained intraocular iron, which is toxic to photoreceptors, but also toxic to the endothelium of the trabecular meshwork. And so this is somebody who has sort of a rusty color to the trabecular meshwork. Also toxic to the lens. You can see this rusty cataract here. We treat it by removing the foreign body, and otherwise treated like open-angle glaucoma. There is a condition called chalcosis, which is similar but caused by copper. This is a patient that I saw recently. He has an injury in his cornea where a metallic foreign body went through the cornea, made an opening in the iris, and lodged in the ciliary body. And you can see that there's heterochromia here as this left iris is rusting. There's a foreign body in the ciliary body here. And lastly, burns. We're mostly concerned about chemical burns, and alkali burns are the worst, much worse than acid. This is somebody with an alkali burn. In Iowa, we see these from people using anhydrous ammonia in the fields, farmers. It's a big farm state. These are terrible injuries. There are 2 phases to pressure elevation. There's the immediate shrinkage of the sclera, which decreases the intraocular volume and causes a sudden marked rise in intraocular pressure. And later there's inflammation and loss of the episcleral outflow channels. So there's no aqueous really leaving these eyes. Treatment is challenging because the usual medications often don't work very well. If there's no aqueous outflow through the episcleral venous system, it's very hard to get any kind of intraocular pressure control. If the conjunctiva is completely damaged, then surgery is very challenging. Often the only viable surgical option for these patients is cyclophotocoagulation. So a lot of topics here. Traumatic glaucoma covers a wide swath of different mechanisms.